Assalamu alaikum, dear students. This is our third session on the topic subacromial impingement syndrome. In the previous two sessions, we discussed the different types of impingement in the shoulder region. Specifically, then we talk about the subacromial impingement syndrome. We discussed the primary and secondary causes. We also discussed the different sources of pain in the subacromial impingement. Then in detail, we discuss the mechanism of subacromial impingement syndrome, which is a vicious cycle. There were three mechanisms which we discussed. In this session, we will continue the previous topic, which was the radiographic investigation, medical imaging in subacromial impingement, the ultrasound, for which purpose the ultrasound is used, what is the purpose of MR, and for which purpose the radiographs are used. So let's go to our slide. So we were here at the end of previous session. The anterior posterior radiograph at the shoulder. अगर हम एपी रेडियोग्राफ पर देखें तो वहां पे हम दो चीजें देखेंगे. That is the distance between the glenoid long axis and the lateral edge of the cranium, and from that glenoid till the lateral edge of the greater tuberosity. हमने डिस्कस किया था कि इसका नाम और वीडियो जो था ये 0.64 है, और ये जितना कम हो जाता है उतना ही ये रिस्क इंक्रीज होता है फॉर ऑस्टियोआर्थराइटिस, और जितना ये वैल्यू जो है बढ़ जाती है उतना है जो है there is chances of the rotator cuff fracture. So higher that value, that will indicate a rupture, a tear in the rotator cuff fossa. So this is that two lines. G alignment from that glenoid till the lateral end of the acromion. So G means glenoid acromion, so this line, and another line, another distance between that glenoid and the lateral end of the greater tubercle of the humerus. Now the ratio between the GA with the GH is known as the acromial index. The next is the critical shoulder angle, and this angle is also measured on the AP radiograph of the shoulder. So the CSA, it is the angle between the glenoid axis and the line through the inferior edge of the glenoid and the lateral extremity of the acromion. So what does it mean? Let's go to discuss it. So this is that line, which is the long axis of the glenoid, and then a line from this point till the lateral end of that acromion. So that is the lateral extremity of the acromion and the inferior edge of the glenoid. This is the long axis, and then from that, this is the inferior edge of the glenoid, and a line in which will connect this inferior edge with this lateral extremity or lateral edge or lateral end of that acromion. Now, the angle which is formed between these two lines, this angle will be known as the CSA, which is also known as the critical shoulder angle in its long form. Normal value of this angle is 33 degree, and at 33 degree, which is higher than 35 degree, that will indicate the rotator cuff field, and lesser degree than 30, that will indicate that there is risk for arthritis, and that lesser critical shoulder angle is being correlated positively with the arthritis. It means the range is between 30 to 35. It is the normal range. The average value is almost 33 degree. If higher the value, higher the chances, higher the indication of the rotator cuff field, and lesser the value, higher the chances of the presence of the arthritis. So this angle is as we can assess them on the AB anterior posterior radiographs of the shoulder. The next thing which we can assess on the anterior posterior radiograph of the shoulder, this is the lateral angle of the acromion. This angle is the angle between the granite axis and the inferior slope of the acromion. A low value may represent a risk for the RC disease. Now, this is much in contrast to the CSA, where higher the value, higher the risk for the rotator cuff disease. But in the lateral angle of acromion, lesser the value and less higher will be the risk for the rotator cuff disease. So one angle which is the long axis of that granite, and then another line which will just pass through the inferior surface of that acromion. So the angle formed here that will be called as the lateral angle of the acromion. So we discussed the three. This is the critical shoulder angle. This is the acromial index, which is the ratio of the GM with the GH. And the last one, it was the lateral acromial angle. The lateral angle of the acromion. Sometimes when there is a chronic case of the subacromial impingement, the tendon of the supraspinatus that may be present with some whiteness on the radiograph, and that whiteness and that brightness on the radiograph, that is just because of that calcification in the that tendon. Sometimes this calcification may cause the inflammation of the tendon, which is termed as the calcific tendonitis. This X-ray is a radiograph. This is a radiograph of a 26-year-old woman, which was presented with the calcific tendonitis of the right shoulder. The patient report intense pain and symptomatology reason for the accumulation of calcium in the tendon of that supraspinatus muscle. So it means we can assess four things on the radiographs and the AP radiographs for that subacromial impingement. And all of them are on the AP view. One is that lateral angle of the acromion, that is the critical shoulder angle, and this was the calcific tendonitis, and the one was the acromial index. In the MRI scan for the subacromial impingement syndrome, we are looking for the subacromial bursa, which is invisible on the radiograph. So on the MR scan, if there is bursitis, so there will be high signal areas on that subacromial bursa. Similarly, associated tendinopathy and rotator cuff tears, they may also be assessed and diagnosed on the MR scan. MR is a gold standard for the message getting these tendinopathies, sprains, and strains. Sometimes some small bodies, white bodies, they may appear known as the rice bodies. And these are just granular bodies that may be seen in inflammatory arthritis and fracture arthritis, for example, tuberculosis or reactive arthritis. So in case the patient is complaining of the shoulder pain, and here are some granular bodies which are termed as rice bodies, if they are present, so the appearance of these bodies will indicate that the person is suffering from arthritis. The arthritis may be septic arthritis, there may be inflammatory arthritis, or maybe reactive arthritis. Another thing which we can assess on the MR scan of that shoulder in subacromial impingement is the distance between the acromion and the humeral head. This black structure, this is the acromion, and this is the greater tubercle, this is the humeral head. This is the distance. There are two red dots. These are actually the upper limit. This is the lower limit. This is the superior most limit of that humeral head. And this is the inferior most limit of the acromion. And the distance between them is the subacromial space. Here in this example, the distance is 7.29 mm. It means still it is okay, fine. If this space, the distance between this acromion and the humeral head, if it decreases less than 7, then there is high chances of the subacromial impingement. So the gap between the acromion upper limit and the humeral head should be greater than 7 mm in order to avoid the occurrence of subacromial impingement syndrome. The reason behind that is the maximum limit for the superior translation, that medial translation in the space for the humeral head is 5 mm. So if it is 7 greater than 7 mm, so the humeral head will be easily translated superiorly without any problem for the surrounding structures. If it is less than 7 mm, then if there is maximum translation of the humeral head, and in that case, when the rotator cuff are weakened and the deltoid muscle is stronger, so then the deltoid muscle actually just rise and translate the humeral head superiorly, while the rotator cuff that place the humeral head, they compress the humeral head in the glenoid fossa. So these rotator cuff muscle, they counterbalance the force of these deltoid muscles. So in those cases where the rotator cuff are weak, thin, and also the subacromial space is narrow, then there is very high chances of subacromial impingement, as the muscles which will counterbalance the force, the superior translation of this deltoid, those muscles will be lacking, their power will be lacking, and the space is already narrow, so there will be high chances of the subacromial impingement syndrome. So again, here the space is less than 7 mm. You can see here in this is that humeral head, this is the acromion, and this distance is, so this is the gap which we should, and this is that, this black color, gray color, this is that supraspinatus muscle, and that is the tendon. We can see here like some brightness again, which may indicate that there may be some bursitis, which is this. This is the area where the subacromial bursa is present, just above the tendon. Known as, this is the subacromial bursa, a tendon of the supraspinatus. So there may be the, in some cases when there is the narrowing of that subacromial space, there is also an etiology for the bursitis, subacromial bursitis. Now, if we look at the structure of this acromion, this is that hook type 3 acromion, which is having a hook. So that is a very high risk factor for the subacromial impingement. Because if because of this hook nature of the acromion, there is a reduction in the subacromial space, which will obviously uh, increase the risk for the subacromial impingement. Now we can see here a black dot here, just like it is the bone, look darker. Then what is this thing within this within the bright color? This black color is basically that deposition of calcium. So this is the tendon of the supraspinatus. This is the acromion. This is the skin. This is the humeral head. This is that muscle of that subscapularis. This is the tendon of the that subscapularis. So if we look here at this black spot, this is basically the calcification, and there is some again brightness, which means that this tendonitis is present, and that tendonitis is because of this calcification. This is known as the calcific tendonitis in the supraspinatus. So the calcific tendonitis in the supraspinatus tendon produce subacromial impingement syndrome, pain during anatomical movement of the arm and during the sleeping. Specifically, during the sleeping, if there is this tendonitis, so the patient will sleep on the affected side, they will be increasing the intensity of the pain and the sleep, his or her sleep will be highly disturbed. So this is somehow the treatment of calcific tendonitis. The calcification, the deposit of calcium, they can be removed, and if it is removed, then there may be uh, a chance of healing of this tendonitis. So this is, we can see here an active calcification, reactive calcification. This is the degenerative calcification. These are the degenerative changes. We can see here, these are those degenerative changes on all the sides. This is the clavicle, this is the acromion, this is the coracoid, and we can see here the degenerative changes here on the coracoid, acromion, and clavicle everywhere. So this deposition of calcium is known as the degenerative calcification. Here, there is no such degeneration, no changes. That is very clear. If we look at the tendon, if you look at the muscles, if you look at the bones, each and everything is clear up, and there is no sign of degeneration. So it will be called as the reactive calcification. Somehow, if you look at this area, this is the acromion, and this is small bones. We can see here, this one is, that is actually a large osteophyte, which is attached to the lower surface of the acromion. This is the supraspinatus muscle. This is the humeral head. This is the glenoid fossa. This is that space within the glenoid surface and the humeral head. This is the deltoid muscle. So this small, but this is not even small. It is a very large osteophyte spur which is present on the under surface of this acromion. So this extremely large osteophyte in the lower surface of the acromion, they create intense pain and subacromial impingement syndrome. So if it is the type 3 hook acromion, if there is spur, all these are the anatomic structures which are the primary causes for the subacromial impingement syndrome. So it means on the MR, we can assess the structure, the shape of the acromion, the presence of any spur, the calcific tendonitis, the gap between the acromion and the humeral head, and any presence of high signal on the inner tendon, indicating of tendonitis, especially on the supraspinatus. Shoulder arthroscopy. This is nowadays it is quite used, uh, and this is the treatment for the removal of those osteophytes. These osteophytes, which you can see here, and this is the lower surface of the that bone, which is in clavicle, and this is a large osteophyte which is being present on the that lower surface. And then shoulder arthroscopy, and through the arthroscopy, these spur can be removed surgically. A large osteophyte which protrudes from the lower surface of the clavicle and which injures the supraspinatus tendon, creating a subacromial impingement syndrome. Now comes towards the treatment. We will mainly focus on the conservative treatment. Most of patients with primary impingement can be successfully treated without surgery. Otherwise, in severe cases, specifically if there is calcification, if there is the increased intense hooking of the acromion, then obviously the surgery would be needed for that acromioplasty, which we also call as the subacromial decompression. So most conservative treatment should be tried first in cases where significant mechanical causes such as large osteophyte have been excluded. Because osteophyte they can be only treated when they are surgically removed from their parent bone. Rest from those activities that exacerbates the symptoms, the non-steroidal anti-inflammatory medication, the NSAIDs, the physical therapy, and judicious use of the cortisone injection injections is the plan for the conservative treatment. So this is that cortisone steroid injection at the joint area. What treatment can be included in the physical therapy protocol for the patient with the subacromial impingement? So there may be specifically stretching of the posterior capsule. We have discussed in detail about the mechanism of that SIS, in which one of the main important mechanism was the tightness of the PC, which is the posterior capsule. So stretching of the posterior capsule should be added to the protocol in patient with SIS. And two stretching techniques that are very effective, specifically the sleeper stretch, is one of the most effective stretching technique for that posterior capsule. Besides the sleeper stretch, across the body stretch is also a stretching technique for the releasing of that tightness in the posterior capsule. Similarly, pectoralis minor stretching should also be added, as well as stretching to the serratus anterior. These are the different exercises and options, physical therapy option, rehabilitation option, which can be used to treat the patient with subacromial impingement syndrome. And all these, the protocol should be according to the evidence-based guideline. So there should be a rotator cuff facilitation maneuver, posterior wall adhesion mobilization, manipulation, scapular movement mobilization, and regularization. The Kibler's exercises for the scapular control, co-contraction exercises, transverse flexion and electrotherapy, tapping, and heat. This is the tapping for the patient, which will also used, which give a postural feedback. This is the scapular tapping, specifically when there is a complete winging, that classical winging of type 2, scapular winging, type 2 scapular dyskinesis, and the entire medial side is being prominent. This is another tapping for that musculature of the, and for placing the scapula on its own side by activating the muscles around it. These are the capillary exercises, which are also known as the open book stretch. Usually this exercise is for the muscles which are present around the coracoid process. This is the sleeper stretch. This is the one of the best stretch used for the stretching of the posterior capsule. That is the patient will be sidelined. There will be 90-degree flexion, 90-degree flexion at the elbow joint, 90-degree flexion at the shoulder joint, and the patient will slowly and gradually just bring this hand by the other hand towards the couch surface again and again. This is another variant of that sleeper stretch. This hand, this is the affected side. The posterior capsule is tight on this lower side, which is on the couch, and the other unaffected side will help to bring this arm into this position. This exercise is known as the Loro exercises, and that is basically used to strengthen and to activate the serratus anterior as well as for the lower trapezius muscle. So these exercises can be added just to activate the SA and the LP. That lower trap are the serratus interior. Some PNF techniques they can be added to just the rehabilitation of that subacromial impingement. These are some diagonal trunk rotation, escapable restriction, PNF techniques for the that shoulder rehabilitation. These exercises they are known as the scapular clock exercises. These exercises include some support on the wall. These hand will be stabilized on the wall and the scapula may be moved in a closed chain fashion to the points of the clock. That's why this is known as the scapular clock. Like there will be a rotation of the rotation like the needles of the clock. And because of that, the scapula is moved in chain fashion to the points of the clock, like here from 1 to 2 to 3. And so that's why this exercise is known as the scapular clock exercise. The hand will be closed chain, that is the supported to the wall. This is another exercises which is in the closed chain exercises. A towel or some cloth will be kept on the couch, and then the arm will slide along that couch surface with support or without any support. This is the vertical closed chain exercise. This is the vertical with this is the horizontal closed chain exercises, and this is the vertical closed chain exercises. Closed chain exercises, the Cordman exercises, rotation with the hand supported. Some weight can be applied at the so can be kept in the hand if the patient can bear that weight. Some other exercises, the empty can exercises position, full can exercise position, different the prone elevation exercise position, and then the pattern exercise rotation, and as well as the external rotation exercise position of the lateral band. So these are the different exercises which can be added to the protocol for the patient with subacromial impingement syndrome. Surgical treatment, the most common surgical treatment is the acromioplasty, which is also known as the subacromial decompression. Mostly, this is required in the type 4 subacromial impingement syndrome, but according to the new classification, both the type 3 and type 4 they require the surgical treatment, while the type 1, type 2 they don't require any surgical treatment. Arthroscopic subacromial decompression procedure, which is the gold standard to surgically treat subacromial impingement syndrome. This subacromial decompression, this is also known as that acromioplasty. When non-surgical treatment does not relieve pain following at least 6-month trial, the doctor may recommend surgery. So this is the criteria. If the person is taking rehabilitation for 6 months, but there is no such satisfaction from that conservative treatment, then he may receive the surgical treatment. The goal of surgery is to remove the impingement and create more space for the rotary cuff. They may include changing the shape of the acromion, removal of that spur, etc. This allows the humeral head to move freely in the subacromial space and to lift the arm without pain because the space would be increased now. The most common surgical treatment is the subacromial decompression, which we discussed in the previous slide, or anterior acromioplasty. This may be performed by arthroscopic technique. In arthroscopic procedure, 2 or 3 small puncture wounds are made because, and this is actually the beauty of this arthroscopic procedure, that very little incision is being made on the skin. The joint is examined through a fiber optic scope connected to a television camera. Small instruments are used to remove bone and soft tissue. This is the B chair, which is used for the shoulder arthroscopy, a specific chair made for that. This is that place of the arthroscopical photos drawing and anatomical landmarks. Shoulder arthroscopy for the acromioplasty. These are the two holes which are made. Clinical osteophyte removal with the special bore. This is the acromioplasty, shading of that acromion, reshaping of the acromion. Some evidence stretching exercises for subacromial impingement syndrome, effect of 6-week program on shoulder tightness, pain, and disability status. So the conclusion was finding of the study showed that flexibility, pain severity, and disability gain can be achieved with a 6-week stretching exercise training for patients with subacromial impingement syndrome. Therefore, shoulder girdle stretching exercise should be recommended early in the shoulder rehabilitation program. This is another study on the virtual reality, exergaming and home exercise program in patients with subacromial impingement syndrome and scapular dyskinesis. So both these conditions, scapular dyskinesis and subacromial impingement syndrome, are on the target. The conclusion was virtual reality exergaming programs. These programs are found more effective than home exercise program at short term in subjects with subacromial impingement syndrome. But this is equally the problem with these effects is they are the short term, and there is no such information about the long term effects of these protocol. This is another study, another evidence. It's showing that the comparative efficacy of kinesiotaping and local injection therapy in patients with subacromial impingement syndrome. So they are talking about the taping and that local injection which may contain that cortisone. The conclusion was, although the improvement in pain intensity at rest, range of motion, and disability were better with local injection, KT may be an alternative non-invasive method to local subacromial injection for patients suffering from the subacromial impingement syndrome. Another single-blind randomized trial, and the conclusion was in subject with subacromial impingement syndrome, combined administration of the focused that short wave therapy and the IE for the rotator cuff. That IE means the isokinetic exercises. For the rotator cuff resulted in greater reduction of pain as well as superior functional recovery and muscle endurance in the short to medium term compared with this extracorporeal shock wave therapy. So that was the end of the treatment and the medical imaging of the subacromial syndrome. Thank you so much to all of you. Have a nice day. Allah Hafiz.